very high of him, Dr. Chirag Thonse. As we know from Dr. Ashish, he is a very prolific arthroscopic surgeon as well as a plastic surgeon. He'll be speaking on management of young arthritis knee, what's latest and what should be done. Dr. Chirag, over to you.
Good afternoon, one and all. On the outset, I would like to thank Dr. Arun Singh and Dr. Ashish Singh, a very good friend of mine, for this invite. It's my first time to Patna. And my topic for the day would be management of young arthritic knee. With fitness being in vogue, we all say 50 is the new 30 or 60 is the new 40. There's an increased zeal towards fitness, and this has caused a lot of brunt on the knee. And there are a lot of issues in the knee which the youngsters in today's date are facing, and one of them is arthritis. There have been lots spoken about orthobiologics. The conventional treatments of knee osteoarthritis could be extended, and now there are a lot of orthobiological treatments which have been well explained in the past by my previous two speakers, and that it's got its own definitive role in the treatment of young arthritic knee. So let me stick on to the surgical management. What options do we have in patients presenting to us with arthritis when they are young? Arthroscopy, high tibial osteotomy, partial knee replacements, and total knee replacement. Of this, arthroscopy is obsolete in today's date. Plain arthroscopy or arthroscopic lavage is no more done to treat osteoarthritis. So let's stick on to the treatments which are available in current date. Either arthroscopy added on with a high tibial osteotomy alone, a partial knee replacement, or a total knee replacement. Now, why does one sustain, or why does one encounter arthritis at an earlier age group? It could be either idiopathic, inflammatory, traumatic, or post-ligamentous injuries. Among this inflammatory arthritis, not much of an options. One wouldn't suggest a high tibial osteotomy or a partial knee replacement. The only option here is to go ahead and do a total knee replacement. Let's quickly look into a day-to-day case scenario. 42-year-old active tennis player comes to you with a low velocity injury, no significant past history, complaints of pain and deflection, and since a few months he's got difficulty in walking. Varus deformity of the knee, medial joint line tenderness, very minimal patellofemoral joint tenderness, and the patient has got no ligament laxity. Extrusion test is positive. All the conservative treatment modalities failed. The patient then does come to you and you get an X-ray, and this is a typical picture what you see. Medial joint line reduced, patellofemoral joint pristine, and the lateral joint line well preserved. It's very important in such situations that you get a good Rosenberg view to get a good visualization of the joint line and to plan up your surgical interventions. We always do get an MRI scan. Any patient who is presenting with you with the medial joint line tenderness, minimal arthritis, or an early onset of arthritis, go ahead and definitely get an MRI scan, because that will give you a well-detailed study of your cartilage and your meniscal status. Now, as you see here, there's a ghost sign which is positive, which says that the patient has a root tear of your medial meniscus. There's a high intensity signal on the axial films that does say that there's something going wrong in the posteromedial compartment of the knee joint. Whenever you see a condylar contusion or whenever you see osteonecrosis of a tibial condyle or a medial femoral condyle, always suspect a meniscal root tear, and you would see here that that one would have a meniscus which is extruded, saying that the medial meniscus is non-functional. Get a long leg standing view. A good long leg standing view would give you a good alignment idea. It would draw in a Miculic line, which is the mechanical axis, and then do calculate your distal femoral angle, your MPTA, and of course the joint line congruence angle. And based on that, whatever you would find deformity needs to be corrected. If it's only a MPTA which is out of parameters, go ahead and do a arthroscopic meniscus root repair added on to a high tibial osteotomy, or if you see that your LDFA and your MPTA both are out of parameters, one would definitely go ahead and do osteotomy at two planes, at both the ends, distal femur and the proximal tibia. Another case scenario, 50-year-old housewife, moderately built with a little bit on a higher BMI, low activity demand, stress X-ray, the medial joint line is correctable. On scoping, you have a bone-on-bone deformity. These are patients with a high joint line congruence angle. These are more of a bald cartilage or a bone-on-bone deformity where there is attenuation of both your tibial and your femoral articular cartilage, and you have a high grade of osteoarthritis. Managing these patients, of course, high tibial osteotomy on a bone-on-bone deformity is out of question. A partial knee replacement would be an ideal option. Why I say so? Because of the high, it's an intra-articular deformity rather than extra-articular deformity. The patient is correctable. That means the MCL is quite stretchable, and a low activity demanding patient with a little bit on a higher BMI. It's very important to note here that unicompartment knee arthroplasties implanted for osteoarthritis with partial cartilage loss, joint space or a partial joint space narrowing have got high reoperation rates. Said that, the crux of the story is that partial knee replacement works well when there is a bone-on-bone deformity and a high grade of osteoarthritis in the medial compartment. Stress X-rays, if it's a non-correctable deformity, if you are not able to correct the medial joint space with the stress X-ray, that says that the MCL is contracted, and these patients are not an ideal indication for a partial knee replacement. One might as well go ahead and do a high tibial osteotomy. Obesity, this is a common problem we all face, especially in urban population, where obesity has become a trend, what I would say. It is difficult to manage these patients with a high tibial osteotomy, and definitively a partial knee replacement would be a better option in such patients. A body mass index of 40 or 45 is also acceptable, and one could go ahead and do a partial knee replacement. Ligament laxities, anybody walking with a valgus thrust gait, or else mediolateral instability, a high tibial osteotomy or a partially constrained total knee replacement would be the procedure of choice rather than go ahead and do a high tibial osteotomy. Chronic neglected ACL tears, a young individual coming to you with about 10 or 12 years of neglected ACL tear, medial compartment osteoarthrosis, and a grade 3 laxity. What are the options you have? When you scope the knee, you would find that there's a high grade of posteromedial wear, which happens because of repeated twisting injuries, and there's a degenerated meniscus. An ideal option would be to do an ACL reconstruction with the high tibial osteotomy. If not, just go ahead and change the slope. That's a slope correction high tibial osteotomy would also suffice. A combined unicompartment knee arthroplasty with the anterior cruciate ligament reconstruction. There have been a few literatures which talk about this procedure, but the long-term results are yet to be expected. Last but not the least, this is the most common problem what we encounter. Patient coming to us with the anterior knee pain syndrome. The grade of patellofemoral arthritis when patient presents to you may be a milder grade, or they may come up with severe problems. In a grade 1 or a grade 2 patellofemoral arthritis, what one could do is do an arthroscopy, do a radiofrequency ablation, and do a lateral release, which would give a longevity to the patellofemoral compartment. If a patient presents to you with something like this, a bone-on-bone patellofemoral deformity with osteophyte, typically called as a penguin patella, a patellofemoral replacement would be the procedure of choice. To sum up, the measure of, as Einstein said, the measure of intelligence is the ability to change. So rather than being just an arthroscopy surgeon or an arthroplasty surgeon, it's better that we all call ourselves as a knee surgeon and provide the best possible treatment to the patient as per as the patient's demand and the pathology. Once again, I would like to thank my dear friend Dr. Ashish and the entire organizing team of Anup Orthopedic Course for inviting me to this wonderful program, and welcome you all to Bangalore for for the upcoming Bangalore Arthroscopy Operative Course, which will be held on November 26th. Thank you.
Thanks, Dr. Chirag, for your